Hi, Laura. Did you say we're live now? Thank you very much. Okay, good morning, everybody, and welcome to the meeting of the Trust Board of Herefordshire and Worcestershire Health and Care NHS Trust. Some specific welcomes this morning, actually. Specific welcomes to three of our new non-executive colleagues. We've got Veena, Carol and Biraj. You're specifically very welcome to join us as to your first board meeting as associate non-executive directors. Hopefully you'll get a lot from it. I know we'll certainly get a lot from yourselves. And also, although you've been here before, Lisa, I don't think I've formally welcomed you to board as our interim Director of Digital and Chief Information Officer. So, Lisa, you're very welcome indeed. Remind everybody that we are being recorded and we are being live broadcast to millions, I'm sure, on YouTube at this very moment in time. If I've got any apologies, I know Sue, the other new Associate Non-Executive Director, has sent her apologies, and we always knew that she couldn't attend this meeting. Tessa is with us. For those who have thought she was going to send apologies, she's changed her diary around to be with us today. Jill, are there any other apologies?
The only one is Martin is obviously here, but he does need to drop out for a short time at 12 o'clock. OK, thank you. If we could then move to the minutes of the meeting. There were two meetings actually on the 8th. If we start with the minutes of the meeting on the 8th of March, which was the routine board meeting. Is there any matters arising or matters of accuracy from that meeting, please?
No, thanks, Mark.
Indicating, so we'll take those as a true record of the meeting. And the minutes of the extraordinary meeting on the 30th of March, of which I was not in attendance and was chaired, I think, by Tessa. Any matters arising or matters of accuracy? Are they OK, Tessa?
Yes, they are, Mark. OK,
thank you. So if we take both of those minutes as accurate, true reflection of the meeting, thank you very much. As they always are, they're excellent set of excellent set of minutes. Thank you very much indeed. The action log. Although I think all the actions are closed, is there anything we need to know about any of those, Jill, in terms of updates, or anybody else on screen?
Not from my perspective. A couple of them are about bringing matters back to future board meetings, and the others are complete as per the narrative.
OK, thank you very much. Nobody got any comments on those at all? OK, complete. Thank you very much indeed. Item number 6 questions. Have we received any questions, Jill? I've not been informed of any.
No, we haven't.
OK, thank you. Declarations of interest are on the website. And of course, just a reminder to all, if you have any changes in your declarations of interest, please inform Jill as quickly as you can. Thank you. Now to one of the most important aspects of our meeting, which is the patient story. And welcome to a couple of guests. I think somewhere on the screen is Carla and Trudy. And so I think the easiest thing for me to do is hand over to Natalie for introductions. Natalie.
Oh, thanks, Mark. So I'll hand you straight over and not steal any thunder. So I'll hand you straight over to Carla, and thanks ever so much for joining us today. So the floor is all yours.
Good morning. Hello. My name's Carla. I've just been asked to come and tell you a little bit about my story from being a service user and also a volunteer within the trust, and sort of just who I am and about me and sort of how the trust has affected me. So I'm going to really badly attempt to share my screen. I've just done a little PowerPoint slide. Hang on. As young as I am, I'm not very good at computers, so I'm still there we go. Can you all see that?
I can't see anything.
Has it not worked? Is it still just me? Okay, 1 second.
Don't worry. I can assure you.
Wait, hang on.
I assure you, Carla, that we're all worse at IT than you are. So please take please take your time.
Hang on, I think I figured it out. There we go. It should work.
Oh,
There you are,
There
Carla.
we
Yeah.
go.
it's coming.
It worked?
Yes, I can certainly see it. And I think some thumbs up from people around the screen. So yes, we can see that. Well done. Thank you.
Okay, cool. Thank you. So basically, I started with a want to do psychology at university. So I began looking for work experience opportunities around mental health and psychology, like in healthcare. So I joined the youth board in 2017. Back when we used to just be a little group of maybe like 5 of us, and we just meet in Waitrose every Wednesday and talk about things. And since then, we've gone on to do loads and loads of amazing things. Probably my favourite project I've been involved in is the Bestie app, which you have probably all heard of, hopefully. If not, it was a mental health app that we've designed for both clinicians and young people to use to help them support their mental health journey and take the pressure off clinicians because it helps young people to guide their own mental health recovery and journey while they're at home, not just in their dedicated time in the service. And then I actually went into using CAM services myself when I was 18 years old. I've been suffering from a mixture of depression and anorexia during secondary school, towards the end of secondary school, a lot around exam time with GCSEs and everything. So I went into hospital when I was just turned 17, so a couple of years after I'd started on youth board. So I did take a bit of time out of youth board to start getting myself better. But even during my recovery, while I was still in services, the team in youth board were very welcoming. They let me come in and out whenever I could, whenever I felt well enough. And it was actually really helpful while I was getting better to be supported by youth board at the same time, because even though when you're poorly, you feel weak as a person, I think, and you feel a bit rubbish, and that like you're kind of defined by what your illness is. And I feel like being a part of youth board, they never once would mention. Some people on youth board knew, some people didn't, but it was never once mentioned, and it never took away from any point I had to give. And anything I said was never thought taken in a from a perspective of a poorly person. It was just taken from me as a young person. And I think that really did support me in my recovery, as well as just giving me lots of experience and confidence as a person, because it showed me that I was independent from my illness. And it's given me a lot of help in that way, which can be a really difficult thing for people who are using CAM services in recovery, to not be defined by just, I am a label of anxiety, depression, bipolar, anything like that. So I really do have youth board to thank for that. I have also, one of the main things I got from youth board was confidence to speak in a room in front of people much more important than me, which is kind of what I'm doing right now. So right now I'm a uni student, I work full time and I'm a volunteer, but I'm here speaking to you guys pretty confidently, and I feel very calm. And that's a skill I've learned over time, is that youth boards taught me that everybody's voice is equal. We all have different strengths, different perspectives on life that are all equally valid and important. And youth board has shown me that. So for example, when we were doing the Bestie project, there was people my age, people younger than me, like I don't know, like 14-year-olds presenting to a board of people like yourselves right now, presenting this app that we created. And we were terrified in the first one. And I remember we were just encouraged, and they just said, they're just people. They're just here like you. Some of them are probably tired. Some of them are probably happy today. We're all just human beings. And the more being in that environment during youth board, where everybody's opinion is equal, no matter their status or anything like that, That's really given me a lot of confidence to not let my age get in the way of anything I've done. So I did eventually go on to study psychology at Bath University, which is where I am now, in the lovely sunny Bath. It's actually really nice out there today, which is rare for here. We've been raining all week. So I've done 2 years at Bath University, and I've also been dipping in and out of youth board the whole time. They can't get rid of me. Oh yeah, sorry, if no one knows what youth board is, youth board is basically a panel of young people within the trust. They're all volunteers, aged about, I think the youngest member might be 14 or older now. I'm sorry if I got that wrong. Up until people in their 20s. And we meet about once a month. It's now on Zoom. It used to be in person before COVID. And we are given projects to do. We work on things that we want to work on to improve services for young people in and around the trust. And also we get sent things that lots of different departments in the trust are working on that affect young people. And we give our feedback on that from the perspective of young people, and we try and sort of kindly criticize them to make them as best as they can be. Yeah, so now I'm at Bath University. I've done my first 2 years while dipping in and out of youth board around my studies. So I've been joining the Zoom calls, still doing work to help out with projects and things when I can, so when it fits around my studies and exams and things. And then my university degree is a placement one. So that means on your 3rd year, you go out into the world and do a work experience placement to do with what you want your career to be in. And by this point, I've decided that I don't actually want to do mental health as a career. I want to do something to do with psychology, but a different branch of that. Something to do with communications, marketing. I'm also interested in events management as well, which is all still related to psychology. It's just as we grow up, our career paths change and things. But I came into a bit of a dilemma in my 3rd year, which was I prefer not to live with my family at home, which is what a lot of students do. They go and live with their parents so that they can move in with them, not pay much rent or food bills or anything like that. And then they work nearby where their parents live for their work placement, because a lot of psychology placements aren't paid at all. They're all on a volunteer basis. But I, for whatever reasons, can't do that. So I would prefer to stay in Bath and live by myself this year. But I ran into an issue, was that I can't really do a full-time work placement with no income and live by myself. So I thought I have 2 options. I can either skip the university placement year and then just work full-time for a year, which is my initial plan. Or I can try and find a paid work placement, which are very, very rare. I didn't manage to find one that I liked because I'm a very picky person. I can't do any work that I don't enjoy because I'll just not do it. So I sent a little message to Trudy, who runs the youth board. And then I said, even though I'm going to be working full time at my job to live stably, is there any way that I can still help out with youth board during this year? And between the 2 of us, we managed to make an agreement between the university and the trust that I would volunteer across a 13-month basis, which made up the hours required by my university to say it was an entire placement year. Because for the rest of the students, they would only be volunteering during term time, but I've been doing it from September to September, so that makes up the same thing. So I've still got my university degree. I just do it, my placement year ticked off. I just do it on my days off from my full-time job, and when I have holiday or when I have a bit of free time or when work's not very busy. And I'm really, really thankful, especially to Trudy, for that. Because it's allowed me to sort of reach my academic goals despite my personal circumstances, which I found has been a bit of a challenge being at Bath University, because I'm sort of amongst the cohort of students that aren't as privileged in the sense that mum and dad would pay their rent if they're going to do a work placement kind of thing. Not that I hold any grudges against my parents, they're wonderful. It's just who you are and how you grow up and everything. So that's been wonderful, and it's also allowed me to take on my first management roles. I work in hospitality. I've done this since I was a 15-year-old girl pouring pints behind a bar, which I probably shouldn't be doing at that age, but hey, that's life. And then yeah, so I've worked with me about the years, in and out of uni. I've always worked in hospitality. And then during this year, I've taken on my first role as assistant manager of a restaurant, which I'm absolutely loving. And I think it's thanks to Youth Board that I actually had the confidence to go for that, because a 20-year-old assistant manager is quite rare in hospitality. And I did get sort of looked at by the general manager going, who is this young girl who has been paired with me to run this restaurant? But it didn't really intimidate me. And I think that Youth Board has really helped me, and being a part of the trust amongst people who seem on paper more senior than me, and being involved in even like recruiting. Like, I've been involved in recruitment boards for like really high up roles in the psychology department for young people, different things like that, being involved in Bestie, and all the projects I've worked on with Youth Board, and really having my opinion listened by all of you and different members of the trust has really given me that confidence to go for things that people my age wouldn't normally go for. So yeah, that kind of brings me to now. I'm still loving hospitality and still pouring great pints, but I'm also managing and developing my skills in that way, and I'm still making Trudy's life even better by by being along the journey of Youth Board as well, and criticising pretty much everything everyone in the trust does, as Youth Board does, and then we hopefully make it better as well. But yeah, it really does give us confidence as young people, to support both our own mental health journeys, whether we have worked in service, been in services or not, because I would say about 50% roughly of us have been in services, and I think that's what really pushes us, the desire to make services better, for other young people like us. But it also develops lots of other skills in different ways that have helped me in different areas of my life, and we really do strive to see everything that is done in the trust sort of from a different viewpoint, sort of black and white on paper. Is this going to logistically work for young people and where we are sort of in our society at the moment? So I really just want to sing the praises of both Trudy and Mandy Bishop, who ran the Youth Board before Trudy did, and everyone who supported us along the way, because as both a young woman and a young student, it's really helped me, but it's also helped me in my recovery as a patient and a service user, because it's really helped me to know that I'm not just my illness. I am much, much more than that. So yeah, that's me. If anyone has any questions, please let me know, or if I've missed anything out really obvious. But yeah, thank you for listening to me, and I hope that was what you wanted.
Thank you very much, Carla. It's more than we wanted. If you could just take the screen down, and then we'll move to questions. And whilst you're doing that, there's so many different interfaces with our trust that you covered there, whether it be a service user in our CAMS, Youth Board. We mustn't forget that psychology training is a large aspect of what we do, and of course volunteering as well. So there are so many different aspects of your journey over the last, probably 5-6 years that actually touch our trust. But we'll move to questions in a moment. I've got a number of hands showing.
Sorry, I'm just trying to stop sharing my screen, but I can't remember how to do it. Oh, I've done something. Sorry.
No, don't rush. Just take your time, please, Carla. Take your time. Whilst Carla's doing that, Trudy, I know you've got your hand up. Was there anything you wished to add before I then move to questions, Trudy? Would that be a useful thing to do?
Well, firstly, I want to say there's nobody more important than the youth board. So when Carla said more important than her, sorry for everybody that's present, but there just isn't anybody more important than them. But it's been my absolute pleasure to work with them, to watch their journey. But I think the most important take home here is that what we get is services saying, well, we're really worried about this young person being involved here because, you know, they're not, might be quite poorly or they're not in the right place. As you can hear, it's actually helped. It really does help. And it's a happy circumstance that they come along to the youth board, and because we're very supportive and we understand that they might be going through a difficult process, that they can dip in and out, and we just keep in touch, just a light touch, just to say hi. But it's made such a massive difference to all of them. I get emails from ex-youth board members that have gone on to do so many things. We've got a GP now. We've got assistant psychologists, mental health nurses. So it is very much the case that they really benefit from this, and they all say, you know, without that on my CV, that's all they were interested in when I put that on my CV. The youth board, they just wanted to know about that, and that's what got me the job. So.
Okay, thank you, Trudy, and thank you and your predecessor, Mandy, because clearly the youth board is active and very beneficial to us in the trust to try and hold us to account in another way. It's been my error that until now, and it will be corrected, I've not visited the youth board. So I will absolutely be doing that, and I do see it as an error on my behalf for not doing so far. So thank you. If we move to questions now, I've got a number of people showing, and in the order that I've got them is Tessa, Janet, Sue and Jamie. So over to Tessa first.
Thank you. My question actually partly relates to what Trudy said as well. As a service user and a member of the youth board, Carla, what messages would you give us as a trust board about encouraging other young people to join us and join you as a youth board member?
Obviously, your clinicians in the trust would have to make the final call whether that person was mentally and physically okay to be talking about mental health issues in quite a lot of detail at that point in their recovery. But I think though people who are at that kind of stage will be in full-time care anyway, or their whole life will be sort of consumed by them getting better at that point. For people like me, who was in sort of, I would have weekly sessions, maybe a few drop-ins and things during my recovery. I had a lot of free time. And I'm going to speak quite candidly about recovering from anorexia, is that it seems like all you do is sit and eat, which is not very nice if the thing you're mentally struggling with is eating. So having sort of an outlet of just something that's completely separate, where I'm valued as an individual, it's so empowering. And it also, if it's something that you feel passionately about, is about other young people getting better, whether that be with an illness similar to yours or something completely different. It's just, I would encourage it as much as possible, because although there are like safeguarding concerns and health concerns, it's actually very beneficial. And I'm sort of walking proof of that, that we should really be looking at ways in which patients and ex-patients can be involved in improving services more. And that's something that I've also been working with the trust doing as a volunteer for the engagement and communications team, is engaging ex-service users to get their feedback, because people who have had good journeys and bad journeys with the trust, a lot of the time most people want to help improve it, and it also makes people like who are in services feel more listened to as well and more valued, and indirectly that can support their recovery too. I hope I've explained that well, but yeah, that makes sense.
Thank you, Carla. Janet.
Yeah, thank you very much, Carla. That was that's very interesting, and enjoyed listening to you. My questions, I was struck when you were talking about actually the value of support and peer support when you were actually undergoing your treatment and your therapy. And I was thinking, actually, you got that support from the youth board, but I think you said yourself there are only maybe 5 or 6 people. And I was thinking about all the other young people and other people, not just young people, but people in general, going through treatment and therapy like you have, and how they might get similar peer support. And I just wondered if you had any thoughts about that, because it was obviously really valuable to you.
Yeah, so there are some groups that you can join and things. I'm not sure what stage CAMHS is at with that now, because there was talk about sort of groups specifically for people with eating disorders to meet and sort of feel that support from each other. Personally, that was sort of coming into play as I was going on 18 then, and I was sort of moving out of child services, and I felt like that, and I was also much better, so I felt I didn't really want to go to that, just personally. So I think it was in the works. Where the stage is at, what stage it's at now, I'm not sure, but I do think sort of a food for thought here is that, as far as I know, the people who have shared within Youth Board the services they used, I think I am the only, myself and maybe a few other people, but not many, have had a journey similar to mine. We've had very different, unique journeys, all with ups and downs throughout our journeys, and great stories of services and some really funny ones as well. And it's kind of nice just to be in a group of people where we can kind of just giggle and just say, I can't believe that this doctor said this to me, and that kind of thing. And I think that was kind of the main bit of support I got during my recovery from Youth Board, was that, like, even though we didn't fully understand each other's journeys and never would, for whatever reason, it was nice to just feel support, but it didn't have to be directly about your specific illness a lot of the time. Because if you go to just a depression group or just an anxiety group or whatever, that's all you're going to be talking about. And then it's like, oh yeah, I went to depression therapy today with my friends, like my depression friends. Do you know what I mean? But it's, Youth Board just felt like I'm just going to chat with my friends. And for whatever reason or not, that day we'd all talk about our service experience. The next day we'd have a chat. We'd just be texting each other about, I don't know, Love Island or something random, like, that was completely different. And it's like, I think maybe being in mixed peer support groups of a lot of different illnesses, of people who are maybe lower risk, that could be something that the trust could look at, rather than just ones focused on specific illnesses. And this doesn't have to just relate to mental health as well. You could have like ones for different types of carers, or groups for maybe people with chronic illness or physical disability, but they're all different types, not just specific subtypes of mental illness or chronic illness or that kind of thing. Just service users who might want a bit of a break from their illness. But when you are in full-time recovery, you may lose touch with people in your life who aren't in any sort of treatment or don't really relate to that area of your journey right now. And also, if people, your normal life friends, have never had to use any sort of service for anything, they're happy and well, it's kind of hard for them to understand your struggles in that sense. But when you're talking to different service users, even if your struggles may not be about the same illness, you still have struggles and can have more empathy towards someone else, because you realize, right, this person will have this kind of struggles, but I'm lucky I don't have those, but I have different types of struggles and that kind of thing. So I think it can be a really valuable thing. It's just obviously working out the logistics. But I think it's a food for thought that we have mixed peer support groups rather than just focusing on specific illnesses.
Thank you, Carla. I'll move to Sue now, and after Sue, or maybe Sue could enlighten us. I think there's a question asked by Carla there with regard to peer support, notably around our CAMS arena. I don't know if any of our executives after Sue, or maybe even Sue, can comment on what is available and in relation to those mixed groups as well. Sue.
Yeah, and say, Carla, thank you so much, because you've articulated the value of youth board so well this morning. And I suppose we've focused a lot on some of the ways it's personally helped you in your recovery, but I'd also like to say I've seen what youth board's done around really helping the trust shape services, the quality improvement. I mean, you've been up for awards, and I suppose it's just to highlight the fact that youth board's actually got its 10th year anniversary this year. And as a trust, we're exceptionally unusual to have a really vibrant youth board with that kind of history. And I did wonder, I didn't know, Trudy, whether you'd got your hand up for this reason, but we're actually looking to showcase some of the work of the youth board on the 31st of October and actually do some quite interactive sessions on how to engage with young people and to build on the work, raise the profile. And in particular, I think we'd like to see more Carlas coming through to youth board and through the trust. I think your journey is spectacular in relation to peer support and then into various roles that I've seen you go into in my part of the organisation. So when you talk about peer support, Mark, we're on a journey. I think we've got a focused piece of work at the moment to really build up our volunteering base and to start to articulate how we can build peer support both into the CAMS arena, but it's not just CAMS. Youth board is all young people. So, for example, we've got our breastfeeding buddies, they're volunteers, and we then see them move into various roles within the organisation. So Elaine and I have been doing some work, haven't we, Elaine, through the workforce plan to really build up that movement from volunteer to peer support into other paid roles within the organisation. So it does vary service by service with the opportunities, but we're really picking out now, how do we scale that up? I think the biggest piece for me is how do we raise the profile of this? Because I don't think people realise the opportunities that sit across our organisation for volunteering and those onward moves into paid roles, whether they're peer supports, experts by experience, etc. So I do, yes, would welcome all of you to potentially attend youth board, obviously not all at once. But if Trudy, we can then run the details for the dedicated event, which is celebrating the 10th year anniversary, to board members and encourage people to attend. That would be fantastic too.
Thank you, Sue. And I think there'll be a number of discussions based upon Carla coming forward today with how we can ensure that the youth board's profile and work and worth is brought more up to all of us. Trudy, you had your hand up still. Did you? Was that a legacy hand, or did you wish to come in again?
Yes, just to reiterate Sue's point, really, but most importantly, to understand that we have young people on the youth board that haven't used our services directly, so they might have family or friends, or so the value of youth board is that they all have very different experiences, very different knowledge base, and like Carla says, it's not a board of young people that are just there to talk about their illnesses, and if they want to talk about their journey, and then they're welcome to, but it's not a prerequisite. It's and to allow them to sort of grow through that, really.
Thanks, Trudy. Okay, thank you to everybody, and Carla, thank you ever so much for coming along this morning. It's very clear listening to you. There's a couple of things strike me. First, you hear people of my age and older say, "Oh, age is just a number." Well, I think we need to remember that for our young people as well, because the value and the worth that you give to the trust and in other areas of your life shouldn't be underestimated. So on occasions, I think people of my age and older and younger perhaps can dismiss young people because of their youth. I think that would just be incredibly wrong to do that, and you've demonstrated that this morning. because I think it's clear to me, and I suspect others on the screen, that whatever you go on to do in life, it's impossible to believe you'll be anything but successful. And we all wish you well in your studies in psychology, and indeed your journey through hospitality, and psychology and hospitality, if that's what you wish to pursue. I think you've opened many eyes this morning. You've impressed us all, but you've also reminded us how important the Youth Board is and how important our services are to young people and beyond. So you've done a fantastic job this morning. Thank you ever so much. You're very welcome to stay and listen to us, but you sound like a very busy person in your own right. Trudy, did you wish to come in again?
Yeah, I think I just wanted to thank Carla, because it's quite a nerve-wracking thing to come and speak to everybody, and she did it very last minute to step in for someone else. So as always, Carla, you're an absolute star, and I'll speak to you soon.
Yeah, thank you all for having me, and thank you, Trudy, for thinking of me for this. Lovely to meet you all.
Thank you very much indeed. Okay, and with that as a foundation for the main thrust of our meeting, which I think is a fantastic foundation, we'll move on, if we may please, to the Chief Executive's report. Sarah.
Thanks, Mark. Just for information for the new non-executives, the purpose of my report is just to give an overview of what's happening nationally, externally in our system, as well as within the Trust. But by its very nature, I cover quite a lot of items, just pull out some of the important ones. But obviously, we'll go into some more detail on a few of them as we get into the more detailed reports during board as we go through the morning. So just to flag that. So if I could just draw your attention to a few things in my report, assuming you've read it. You'll note on page 5, which is 42 of Diligent, that I've mentioned the NHS Delivery and Continuous Improvement Review. NHS England have reviewed its approach to continuous improvement and have really concluded that there needs to be a much stronger focus around quality improvement moving forward, and they're implementing this within their own organisation, but also looking to organisations to really strengthen and adopt our improvement approach. So that's something you'll hear more about in the coming months. You can see there's a leadership programme being developed, an improvement approach and a national improvement board. The important thing to say is that they are not recommending one specific methodology. So some of you will be aware that Worcestershire Acute Trust is doing the Virginia Mason programme, for example. There are other improvement programmes, but nationally they're not recommending one particular programme. They're really just encouraging the whole of the NHS to refocus around improvement. So I think that's really positive and more to follow. On page 6, just to draw out so that you note that the liberty protection safeguards, the implementation has been delayed. So just to note that. I've covered the pay offer. You'll have seen this in the press, no doubt. It is an unusual position because we're in a position where the unions aren't all in the same place with their conclusion around the pay offer. But we are expecting the pay award to be made for agenda to change staff in June. Just to note, because there is back pay due, we are obviously very conscious that there is a risk that may cause some difficulty for people, depending on their individual circumstances. If they get one big lump sum, it can affect benefits, etc. So we're putting some mechanisms in place to support staff where that might apply. Are you right, Jamie, to hold your question till I've finished, or shall I carry on, Mark? Or do you want me to stop now?
No, we'll carry on and then pick up questions at the end. So yes, please carry on.
On page 7, you'll note the industrial action is mentioned. Board have been kept up to date as the industrial action has progressed. We still are expecting some potential further action, but it's reliant on the outcome of current ballots that are out with the RCN and, as you know, with junior doctors. So more to follow, I'm sure, on the industrial action, but the agenda for change offer has been made. You'll note there's some new guidance on arrangements for delegation, and that's particularly relevant for the mental health collaborative. So Sue has been sharing some of that with the collaborative as appropriate. Towards the bottom of page 7, I just want to highlight the NHS oversight framework, which you're aware of, which oversees our performance, has been refreshed. The system has been reconfirmed as segmentation 3. But there is a recommendation that we as a trust move from segment 1 to segment 2 for quarter 4 of last financial year, and that's because of the CQC outcome around Hillcrest and some overall issues around system-wide mental health targets. We'll cover that further in the finance and performance report. Urgent care, as you know, is a common topic for us, but just to draw your attention to the Ian Sturgis review. So Ian Sturgis is a clinical expert who has done a lot of work with the National Emergency Support Team to work with systems to support urgent care pathways. He's been to our system, and in this context, I'm talking about Worcestershire. He's been to Worcestershire a number of times over the years, and he returned this year and has done a further, more detailed report. The report has concluded and will be circulated and shared shortly. There are a lot of actions to be followed through in that report. Some are specific to us, which Rob Cunningham, I'm sure, can pick up when we get onto the operational reports later. You'll note that Matthew Hopkins, Chief Exec of Worcestershire Acute Hospitals Trust, has got a new job and is leaving the Trust at the end of July. The Trust are currently considering succession arrangements, so we'll report those to you once we hear more. But Matthew is leaving at the end of July, so I want to wish him our best wishes in his new role. Some great news on page 9 I do need to draw out, which is that the finance team have been looking at training, development and CPD accreditation and have gained full accreditation. This still doesn't trip off the tongue, Rob, so I'm going to have to practice, but full accreditation as a training and CPD registered employer with the Association of Chartered Certified Accountants, the Chartered Institute of Management Accountants and the Association of Accounting Technicians. Which is fantastic. Rob has all the beautiful framed certificates in his office. If anybody's passing, no doubt they'll be on the wall shortly. Care notes, you'll be aware, for the new non-executive, Care notes is our electronic patient record. It was affected by the national IT cyber attack last summer. It's been a very long time coming back, going through all the cybersecurity checks. In February, we started to roll it back out to all services. So I'm pleased to report to the board that all services that used Care notes before are now back operational on Care notes. The only issue, and it'll no doubt come through the performance conversation later, is it is still continuing to affect our ability to monitor our performance indicators because we don't have all the requisite data. On page 10, you'll note that Sir Jules Thorne House at Osborne Court in Malvern has been inspected by Ofsted. For new non-executives, this is a learning disability replacement care service for children with complex needs. We're delighted that both of the bungalows have been assessed as good on Ofsted, and I think we're very close to outstanding. So I think the team are really focused on that goal for the next inspection, but some great outcomes for them from that inspection. We've signed up to the Stay Connected pledge, which is led by Public Health, which is around combating loneliness. Myself and Mark have signed the pledge now. Just to reinforce that we've done a lot of work in the county on, particularly in Worcestershire, partly in Herefordshire, about loneliness. But the difference this time is this is also focused on loneliness amongst staff. So really important. It's recognising that even if you work, you may well still be lonely. And I think it's really quite important, Tessa, I don't know if it's an issue for the Workforce Committee at some point, but with the hybrid way of working, if somebody lives alone and they're working in a hybrid way and they're not meeting colleagues very often, it can have an impact. So we're asked to specifically sign up to some ways of improving the support and buddying arrangements for our staff, which I think is all really, really positive. On page 11, just to note that Mark has had his term extended, which is great news for all of us. So that is noted in my report, and Mark's term will now run to the 31st of March 2026. And as you know from Mark's introduction, our new non-execs have joined us today, and that's fantastic. Gary Morgan left the Trust this week, and I do want to publicly express my thanks to Gary. Gary was our head of communications. He's been in the Trust for almost 10 years, I believe it is, and has really driven our approach to communication, and particularly done all the fabulous work we've done about some of the mental health campaigns, Arts in Mind, and the Now We're Talking campaign. And he's actually been very prominent in the system mental health collaborative work, trying to build one platform for the whole system around mental health and wellbeing. So I'd like to express my thanks to Gary. And as you'll know, Fee, who is Gary's successor, is on the gallery today, and hopefully you'll all meet Fee soon. The other appointment of note, which isn't in my report because it was going through a HR process, is, but you'll be aware the board has been really focused on freedom to speak up and making sure that we expand our capacity around freedom to speak up guardian roles. Narai Majuri has been our guardian for a long time and has done a great job, but you'll be aware we've agreed to increase the hours in this role to 3 days a week, and I'm pleased to confirm we've appointed Natasha Morris-Day, who starts on the 1st of June. Natasha is very excited about this role and very energetic. So I think she's going to be fantastic and really add to the work Narai's done to date. So just to confirm, because I know the board were particularly aware of that. And then just finally, I just wanted to touch on the NHS at 75 conversation. It's the NHS birthday in July, and NHS Assembly, which is a national forum of partners, NHS providers and the public, have been asked to do a piece of work on what we should be celebrating around the NHS and what we want the NHS to focus on in the future. And the Assembly, rather than coming to their own conclusion on that, have actually written out to all chief execs a rather tight time window of a few weeks, but asked us all to have a couple of local conversations with staff around those very questions. What should we celebrate and what's in the future? So just so the board are aware, we've been asked to do that. I have already had 2 discussions, one with the senior leadership team and one with the staff voice group. It says choice in the paper, so it should say voice, staff voice advocate group. And the community learning disability team are currently going through the conversation as well. So we will be feeding in some comments from staff to what staff feel about the priorities and focus for the future, which I think will be really helpful. Thank you, Mark. Sorry, there was quite a lot to cover today.
No problem. Thank you, Sarah. Some important stuff there. Jamie, you're showing your hand.
Thank you, Sarah. Just a quick question and a comment at 2 items right at the top of your paper. The statement from government on social care. I know there was quite a bit of controversy on the previous statement because the resources earmarked for social care were then diverted towards NHS costs. And I wondered if the latest statement provides any greater clarity about resources that are actually going to be available to help social care. And then while my mic's on, I just wanted to say how positive I felt about the outcome of the Hewitt review. I think the key recommendations there seem spot on, and it's be looking forward to seeing what results that has for the way ICBs develop across the country.
Thanks, Jamie. In terms of the social care reform, I think it's still a commitment, as we've seen before. I haven't seen anything concrete around funding yet, unless Rob or anyone else on the gallery has. So not yet. The commitment is there as it was before. And thank you. Yeah, Patricia Hewitt's really made an effort to engage heavily with, I know Mark's been on one of the roundtables and so have I, engage with the sector about our views on this. So I think it's really helpful. I think there's a few targets are going to be quite interesting how they proceed, particularly things like reducing national targets. I think everyone would welcome that, but as you know, we have a lot of targets, so it'll be interesting to see which ones and how it's decided which ones are the most important for patients. So I'm sure more to follow on some of those areas.
Thanks, Sarah. If there's nobody else showing, there's a couple of things I was going to mention. First, it's probably because Sarah's got a professional nursing background. She glossed over the fact that last week was international, on the 12th of International Nurses Day. So I think Paul can record our thanks yet again to all our nursing staff, not only within our own trust, but across the system as well and beyond, for the dedication they show on a daily and hourly basis. I think board can also record its congratulations to Natasha. As Sarah indicated, we all see the freedom to speak up guardian role as really important across our trust, not only to act as the role, but to develop the role as well. And I think from feedback from Sarah, Natasha's extremely motivated towards this role, and we wish her well in that. Similarly, I think as one of our major partners in the system, I think we can all wish Matthew Hopkins well for his new appointment. He's got a very large trust to try and deal with over in the east of the country, and we wish him well on that, and thank you for his role over the last, what must be now 5 years or more. I would guess he's been chief exec at the Acute Trust. And finally, of course, the two others, the Sir Jules Thorne House. I mean, it can be easily glossed over, but getting a good rating, and I have seen the report, nearly an outstanding rating from Ofsted, is not an easy thing to do. And I think when you read that report, you see the care and compassion given by that team is fantastic, and it's a testament to their work. And our finance team, Rob, you do much of it behind the scenes, and a range of staff that don't get themselves in the spotlight very often, but without their hard and diligent work, our finance function would be not what it is. So I think getting those accolades is testament to the work they do very quietly behind the scenes. So I think it's right the board congratulate them on that as well. So thank you, and thank you for that comprehensive report, Sarah. It keeps us up to date on the really live issues across the trust and indeed the wider system and nationally. Thank you. Okay, if we can then move on to the board assurance framework and the high level risk register. Jill.
So the board assurance framework, as everyone will be aware, represents the principal risks that may stop us achieving our strategic objectives. And just for new members of the board, the way that we agree the contents of our board assurance framework are from the higher level risk register, and so risk management occurs throughout the organisation, and the higher level risk we then consider as to whether they should form part of our board assurance framework. We now have 6 major risks on the board assurance framework as freestanding risks. We previously removed COVID as one, having believed that we've moved into a different phase, and whilst it's still present and impacting in some ways on our staff and on our services, that actually it's become much more business as usual. In terms of how we continue to measure, monitor and mitigate risks, this is obviously a feature of the work undertaken at the front line in corporate services as well, and there's a regular review of risks and through the SDUs and corporate teams, leading to monthly meetings with the exec team where all of the higher level risks within their portfolios are reviewed, and there's a support and challenge of those as well. What we have in the report are a number of different papers. We have the current board assurance framework, which is the document that I'm asking board as to review and approve if there's no further additions. We identify the summary of the top risks that are across the organisation. Obviously, these vary month by month, and we continue to conduct some support and challenge around some of those to make sure that they are appropriate, timely, and that they are being updated. We also look at the trend data of risks as to how they vary to make sure that obviously this is an active process and that risks are being managed. And we also have on there at the back of the report the 7 levels of assurance, and for the new associate non-exec directors, these are how the committees assess how assured they feel about reports that are received by them for assurance purposes. And you'll see that in the subsequent reports that are received for assurance that the 7 levels are used, and that, so I've included that as part of this paper just so that you've got a reference point as to when people are talking about level assurance level 3 or 4, you can obviously see what is happening there. In terms of the board assurance framework, the changes from the previous version, the additions to the board assurance framework are updated in red. There's obviously been quite a significant consideration from a finance perspective, from Rob in particular, representing the current position that we find ourselves in, both as an organisation and as part of the system. So the board assurance framework's presented for approval and for any comments, and as well as the details as to around how we manage risks throughout the organisation. Happy to take any questions.
Okay, folks, anybody got any questions on the risks or indeed the BAF? Sarah?
It was just a comment on the BAF, on the ICS risk, which is on page 65 of diligence. Just when we set that risk, it was very much in the uncertainty of how the ICS structure was going to be set up, and whether it was going to be too bureaucratic, whether it was going to really encourage partnership. I just wonder, now we're sort of almost a year down the line, whether we should review the content of that one, because I think probably the emphasis needs to go on to the second part of the statement, which is whether the benefits of integrated care are being realised rather than a structural issue around the ICS, because actually I think the ICS has done quite well in trying to minimise bureaucracy, and we've now got the joint strategies and forward plan coming through. So it was just a comment, Mark. I'm happy with the risk, but perhaps we take it away and just think about just a different emphasis, if that's all right.
Yeah, I think that's a good point, because the ICS and ICB are sort of bedding in, continue to bed in, but there's certainly, we know far more about the effects we have on it and it does on us now. So I think that risk could be relooked at. I've got a couple of things, but before that, does anybody have anything at all? Okay, we will revisit this at the end of the agenda. Sorry,
my hand is
Steve.
up. I don't know whether you could see it. It's a comment really on page 66 of Diligent, which is the workforce risk. We've currently got a score of 16, and it's gone from an initial assessment of 20 to 16 because the consequence score has obviously been dropped over time. I just wondered whether we need to question that, because we are seeing the consequences of the vacancy levels and the impact it's having financially and our ability to provide services. I just wondered whether that should be revisited, is my comment.
Anybody on the screen wish to comment there? I can't disagree, Steve, but I don't know, Sarah or Elaine, or Matthew, even as the person with a lot of the people in your role.
I was going to say, sorry, Mark, I jumped in just as Matthew put his hand up. I was going to say that seems a very fair point. I'll take that away with relevant colleagues to review that and look as to whether actually we need to change that.
Okay, thank you. The couple that I had, Jill, one, I was seeking some assurance around risk 1295, that we do have all the relevant equipment for our paediatric clinics, and we've mitigated that. Risk 1295 as, and the second one was, although I don't deny the risk that's showing on 1286, which is the dysphagia team, I was a bit surprised to see it rise to this level, in that it seemed very, very operational, but maybe I'm reading it incorrectly. Matthew, did you wish to comment on the paediatric clinic equipment first?
Yes, our belief is that this is only a short-term problem. That the challenge has been that during COVID and when we were running clinics differently, a lot of equipment was moved from one place to another, and this led to some of the equipment. So equipment's still available, but it hasn't been tested and recalibrated. So that's being addressed immediately. It was discovered on audit, and we expect an early resolution to that.
Thank you very much, and clearly it shows that our audits are fit for purpose in that sense. Jamie.
Thanks. The more we get this format of reports, the more helpful it is. I think this is a really good good summary, but I did want to query. I think there might be a problem with risk 1212, which is the refers to Stonebow, but the explanation seems to be talking about learning disability staff. I think one of those is either the explanation is wrong or the heading's wrong. That might be one for you to take away, Jill.
I think
John has put a comment. Chief Medical Officer put a comment about the mix-up of that. John, perhaps you can articulate that, please, John.
Yeah.
I'm sorry. There must be a mix-up in how the data is extracted because it's combined to different. I think it's a technical error. Yeah. Might be a technical error.
Yeah, I think what we can do is we can circulate to board outside of the meeting. We'll just reflect that just so you've got the accurate version and update Diligent and the website so that we've got the right. Sorry, I think my sound went off there. I'll circulate something and update it on the website so that we've got the accurate information.
Okay, thank you. Can anybody comment on that risk 1286, the dysphagia one? It just seemed rather operational, whereas the others tend to be sort of quite significant strategic issues. I'm not clinical, so I wouldn't pretend to fully understand.
I don't know the detail, Mark, but I presume it's obviously showing because of the score level that they've given to it, and it's because of the importance, obviously, of swallowing in young children. So, yeah. But I don't know the specifics, but we can take it away and get some more information emailed around.
Okay, if there's nothing else, can we agree the BAF as set out and as amended by Jill, subject to the one look at the issue raised by Steve, which I don't think there's any disagreement, Steve, to your view, actually, that it's perhaps shouldn't have come down. OK, I will take the nods around the screen as being agreement, and we'll move on then to our strategy and partnership. Sue.
Thank you, Mark. So just for new board members, this is a update which comes to every board meeting against with progress against the key priorities that we've set out as a board that we want to take more oversight of. This is not the totality of the work that's happening across the organisation. There are a significant number of programmes that are overseen by the Programme Management Office, and they report into Programme Management Board, which is an executive meeting that meets once a month. What we did last October, we had a board development session that said what were the key areas that we as a board wanted to see. And that was really to ensure ourselves that those significant transformation programmes were getting full visibility during board meetings. And you'll see them laid out here. They are attraction and retention. They're a number of urgent care initiatives, children and young people services transformation. We've got a piece of work that we kicked off where we had an update at the previous board meeting around the adult mental health inpatient services. We've got community mental health services. That's been a transformation programme that's been nationally set, and that's been rolling out now over the last 2 years, and some work that we've been undertaking around psychological therapies, so IAP transformation. I wasn't going to go into the detail, but what we wanted to see at board was what's the progress since the last meeting, so that's the activity since March. What are the key risks that we need to be cited on as a board, and what can we expect to see in the next reporting period? So you have all of that laid out in the paper. I think I also wanted to flag we need to keep these priorities live. We set them in October, and we can see already that we've made some significant progress around IAPT in particular. I think we've gone at a pace there that's been really, really impressive. So the PMO will be taking a deeper dive into that. But the recommendation at the moment is that would probably return into business as usual, so wouldn't need to come to the board, and actually would be looking to replace that priority with the electronic patient record activity, which we know is a significant priority for us over the next 2 years. So just to have views really on people comfortable with that approach, because I think we do need to keep this list of priorities, those really significant ones that we as a board need that visibility around, and happy to take any questions on the detail in the paper itself.
I've got nobody showing, Sue. So I'll offer comment on what I think is now referred to as talking therapies, the IAP. On these priorities, I think we should see a stabilisation of whatever issue it is. So the improvement and then stabilisation, and then it's removed. I think when we reach an improvement, to then remove it before we see a stabilisation, I think might be just a little bit early, because it's that continuity of the improvement that we would want to see as a board, I think. So my view would be, let's make sure things are stable before we take our eye off that particular ball. But I'm not suggesting that, you know, that's just my view from the chair. I think I saw somebody else show. So Martin, please.
Yeah, sorry, I was having a bit of difficulty putting my hand up. Sue, I just want to reflect on your comment there around these priorities were set in October, and we still have 2 very high-profile ones in the red zone. Do we have enough resources focused on those red zone areas in order to be moving them up the tree? The assurance tree, and when do we expect to see that movement happening?
The one that we've got. Oh, sorry, Martin, I think I'm getting a bit of feedback. Obviously, one of the areas where we're still further down on the assurance levels is the getting it right first time, and that is just a project status piece. We're obviously at the early stages. We've now signed off the project initiation document. We've got the work streams now meeting. They are scoping out now their activity, so you can expect that now to progress and move forward. So I think that's more to do with just the status, and it's obviously early days. And the other one is we're obviously still working around the workforce recruitment and retention, which we know is it is a tricky dial to shift. We've now got the metrics around that, so again I think we're going to see ourselves now at least having much more visibility about the granular activity and whether that's making the impact. So having the metrics in now will enable workforce committee and board to get more assurance whether we're actually nailing down the right activity to get the outputs that we need around recruitment and retention. But I'm happy for Elaine to put more comment in if that's helpful too.
John, I think you wanted to come in.
Yes, thank you, Chair. Just to add a bit more detail on the GIRFT, the programme actually only started from the 1st of April, and the assurance level given is for the overall programme. We are going to plan, and probably it will take until around August, September for us to see some outcomes and impact of all the actions that are taken. So that is the time we are probably anticipating seeing a movement on the assurance levels.
Thanks, John. Anybody else? I think Sue, Jamie.
Thank you, Mark. My question was on a specific programme, which was the Community Mental Health Transformation Programme. And the report refers to next steps, including strengthening the locality-based model through more relationship building with PCNs. And I wanted to endorse that and ask a question, because from a number of my visits to mental health teams in the last few months, I've the subject of relationship with local GP practices has often been quite an important one and an area of underdevelopment. And I suppose my question is, and perhaps it's one for Matthew or Sarah, I'd like to know how we're approaching this strengthening relationships with PCNs. Is it something that's happening at a local level with the local practice? I suppose, or rather, and is it, to what extent is it being done at a strategic level with yourselves and county level activity? Because I just think it needs some seniority, some strategic leadership to build this, and we can't just rely on the local practices. I'm sure the answer is both, but I'd like to hear a little bit more about how we're tackling this strategically.
I think we'll come to Matthew first, and then I'd like Sarah to comment on the wider system area. But Matthew.
I mean, it's working, Jamie, at a number of levels. So we're certainly engaged in place level partnership boards, both in Herefordshire and Worcestershire, which involve primary care leads. At a slightly lower level, we've got the mental health medical leadership meeting, which occurs monthly, at which we meet with all of the GP mental health leads across Herefordshire and Worcestershire and discuss partnership issues. The associate medical directors also meet individually with GP PCN leads. And then finally, at a very local level, clinical managers from the teams are developing relationships with individual practices and PCNs as a whole. At that level, I mean, that's the level that it probably really counts. We've seen some really good progress in PCNs that have got very proactive GPs with a strong interest in mental health. And I think probably we're slightly behind or developing the relationships in areas where the GPs are probably slightly less engaged.
Want me to add, Mark? I think Matthew's covered most of it, but just a couple of points is, I think one of the big differences with the ICS is that primary care is represented in almost, well, every meeting I can think of at every level. So obviously there's primary care representatives on the ICB board, and as Matthew said, on the place board and locally around mental health. On the urgent care boards, at each meeting you go to, there is always primary care representation, and the informal chief exec meetings we have for place as well, we include primary care reps. So there's a really strong increase in visibility and engagement and inclusion of senior primary care leads, and I think that's really positive. So I think you see that at every level. I think some of the areas around relationship building that we probably need to still continue to strengthen, to be honest, are around some of the smaller local things, particularly things like information sharing. I think we can all see from primary care activity is really gone up, and we all know GP practices are extremely busy. So it's trying to find the best ways we can to make sure we're communicating, that everybody knows what's happening, how we're interfacing, and that's where, in a way, the neighbourhood team links come into their own, isn't it? Because the practice has a named person that they can look to as well if they've got concerns or queries, so it should really help. But I think it is genuinely at every level, and I think it really is significant. I don't think it's a token gesture, this. I think there is a significant increase in primary care presence and influence across the whole system, which I think is really positive.
Thank you, Sarah. And you'll notice, if you haven't already noticed, Sue's put a comment in the comments section about wire forests and picking learning from that and seeing if we can expand it elsewhere. Okay, thank you for that report, Sue. It's developing as exactly as we wanted, and I noticed this time around you got the progress there, so we can track progress against these things. And it seems to be a working vehicle for us as a board to be able to monitor the progress in what we consider to be our key and high risk areas. So thank you very much indeed, and I think board can note that. Okay, moving then to our committee reports, and we'll do this via anything exceptional in the reports that needs to be reported, and we'll kick off with Janet and Quality and Safety Committee. Janet, thank you.
Lovely, thank you, Mark. Yeah, you'll see that we've got a number of levels of assurance here, and do spend quite a lot of the meeting discussing assurance levels. And I think the important thing we've said before about the assurance level process is actually the discussion that it generates, as well as the actual assurance level itself. I just wanted to pick out a couple. The first was the mental health transformation. That was level 2 at a previous meeting, but we had a report around staffing and holding lists improving. So we were pleased to be able to recommend an increase in assurance level, and also actually have the reporting of that going through the integrated governance group rather than coming directly to Q&S. I also wanted to pick out the clinical audit forward programme and update, which we gave a level of 3, just to say that actually I think the people looking at this have been quite brave and identified that a number of clinical audit projects have come forward in previous years which either haven't been completed. I think, recognising that people have been too ambitious, and so the programme has been cut back to those which actually are seen as significant, and this will enable the group and the committee to monitor progress and actually look at change that comes out as a result of that audit, rather than just ticking boxes. So I thought that was a real improvement, and a sign that looking at assurance levels actually does deliver some change for us. A couple of other things, or one other thing was the Resus Committee annual report, that we did note that actually the training levels aren't improving. I think one of the reasons for that is obviously that a lot of this training has to be delivered face to face. But we have asked for further action and another report, and we're going to look at this specifically in 6 months' time to see if we can actually crack this particular one. I think that was the only other thing I wanted to pick out, was that we have been using a risk summit approach for both Hillcrest and for community paediatrics, both of which I think have been referred to earlier. But we're actually looking at those being reported through integrated governance in future. But we have identified a potential quality concern around ADHD, adult attention deficit hyperactivity disorder, in that actually the amount that appears to be commissioned is being vastly exceeded by the numbers of referrals, and so there's a long waiting time. So we will be actually keeping a monitoring eye on that, because that could be something which causes a problem going forward. So I didn't have anything else to add, and obviously we do have the quality report coming a bit later on in the agenda. Thanks, Mark.
Thanks, Janet. Some great work going on in that committee, as all the others. Nobody's showing, so thank you. We can note that report and move on to workforce and Tessa. Thank you.
Thank you, Mark. I think the main things to point out from the Workforce Committee is, for new colleagues joining us, the Workforce report we give 2 levels of assurance to. One is, if you like, around the workforce HROD elements, and the other is around safe staffing. And obviously, whilst they link, there can be different levels of assurance on them. So the workforce element got an assurance level of 2, partly because this is a major risk for the trust, and progress is being made in some areas, but is slower than we would like it to be. So there's a need to really look at the pace of progress on that. Safer staffing, we gave an assurance level of 3. Whilst there are areas of concern, actions have been taken to start to address these, and things like the change in bed numbers at Hillcrest, and therefore the level of staffing, and the recurrent block booked agency staff at Hillcrest have helped to address some of those safe staffing issues. I think the other thing I wanted to point out was we have changed the way we look at the performance dashboard in our committee. We welcome Charlie Windsor, who's coming to present that every committee meeting now. But to note that there are now 5 recovery plans required for the Workforce Committee to oversee. The recovery plan that came to the last committee was not in the right format and didn't give us the level of information that we required. So actually we've asked for all 5 recovery plans to come in the correct format to the next Workforce Committee, where they will be given an initial level of assurance and then monitored through committee. And I think beyond that, everything else is in the report. Thank you, Chair.
Thank you, Tessa. Jamie.
It's only a very minor point, Tessa, but the format of these reports differs across each of them. And in your committee, it shows the level of assurance given by the author of the report as well as the committee. But presumably, all we need to see here is what the committee gave it. Yeah.
I absolutely agree. I don't know why those were on this time, Jamie, but they should come off. It should be the level of assurance that the committee gave that comes to board.
And I think it's fair to say that there's going to be a slight change in how we report this from our next board meeting. I'm sort of looking at Jill, and I don't like that quizzical look, as in Jill, what are you talking about, Mark? I thought we were going to combine these along with our quality reports in each area.
I thought that was going to be something that we were going to talk about at the board effectiveness report going for at the end of the agenda, Mark.
As ever, you're right. I've jumped the gun. Natalie knows all about that because I've done it twice with her in the last week as well. So, okay, thank you. That's a look forward for us all.
Mark, can I just add that we are trying to make sure that the workforce agenda mirrors more closely the quality and safety agenda in its layout and format and the process, not in the content, obviously, but just so that we have the consistency across the committees.
Yeah, and the only other comment I was going to make, Tessa, is the honesty that's reflected in your levels of assurance, and the honesty merely reflects the difficulty of the arena. The arena that Elaine, yourself and that committee work in is incredibly difficult workforce, because we all know that the problem's there, and we're not hiding away from it in any way, shape or form and hitting it head on. And where we're struggling because of the national context and local context, we're stating it so. And that's why there is assurance levels as low as they are, because it reflects the difficulty in which you all work in. Thank you. If there's nothing else, we move to Stephen.
Thanks, Mark. Just wanted to emphasise the reports around assurance, and then happy to take questions thereafter. Obviously, keen to note that given financial performance, we were able to give an assurance level of 6. It would have been 7, but obviously our outturn on agency spend, which again reflects the workforce comments earlier, clearly didn't allow us to give that full level of assurance. But nonetheless, as Rob will report later, another good outcome on the financial stewardship of the organisation. On trust performance, obviously two issues. There are, or maybe 3 issues, I guess. There's obviously we're going to fall to segment 2 in the oversight framework as a result of the Hillcrest requirements for improvement, and there are some of the metrics in our KPIs that obviously we're not delivering as we would prefer to be. So hence the assurance level was 5 on our last discussions. I think it's worth noting the final assurance level, because it gives the impression potentially that there's a lack of assurance on the recovery plans. It's less that and more that there were some recovery plans that are still to be presented. And so consequently, we wanted to ensure that we were keeping that high on our agenda, that those assurance, or rather those recovery plans come next time, and we can debate the significance of those. So hence the assurance level of 3. But the rest of the paper, I'm happy to take questions.
Okay, I don't think anybody's got any questions for you. Very comprehensive. Thank you, Steve. We can note that then and move to Martin and the Audit Committee.
Thank you, Mark. The Audit Committee in April is focused on making sure we've got the preparations in place for the year-end audit and starting to come through with all the reviews and audit reports that we need in order to successfully close last year-end. That said, I'll go through 4 issues that we particularly discussed and I wanted to highlight. Firstly, following an audit around our payroll services, we have got an issue. It's an ongoing issue that is consistent with most trusts within the NHS, but also we want to make sure we're focused on driving down overpayments, and that has gone back to Workforce Committee for a piece of work around a joint piece of work between our HR team and our service provider, NHS Shared Business Services for payroll. In terms of internal audit, we have had a draft audit opinion which is currently being finalised to provide significant assurance around the core areas that they need to focus on for financial services. So which is a huge, we've become a bit blasé about our significant assurance, but it's no mean feat that we get that year in, year out through the hard work of the finance team and the controls and assurances we have across the place. So it's good to see that continuing. The third area highlighting is that we go through a number of areas for the year end. So confirming we have approved the going concern and accounting policies for the year, and that will be formalised in a statement from management and the audit committee as part of the year end process. And we have signed off the submission to the NHS Counter Fraud Authority agency in relation to meeting our requirements on that, and very glad to report that we have a green report on that, which the Finance Director Robert and myself have both signed off on the necessary portal. The final thing I wanted to raise, which we'll pick up later in the board effectiveness piece, but for the first time we've looked at a report of the principal committee effectiveness and the coverage of all the areas that we need assurance on as part of the board assurance framework. The one area that's highlighted in the report that we haven't quite got right yet is consistency in the performance management framework, which Tess has alluded to in relation to workforce, and getting that consistency across all our committees in the way we approach the performance management framework. And that's work to do over the coming year. And that's my report, Mark.
Okay, thank you. Anything on audit committee from anybody? No. Okay, thank you very much, and we can note that and move on to the mental health collab. And Jamie, please.
You'll see we've gave assurance level 5 on performance issues. This was largely reflecting the upturn in a number of the key indicators, albeit early days, and but progress is moving in the right direction. And the recovery plans showed a strong framework for moving forward. Assurance was at level 3. There's been some improvement in mental health placement discharges, but the underlying problems of Section 117 remain, and the long-term answer to that is to do with avoiding admissions, which is a much bigger piece and longer-term piece of work. In relation to quality, it shows an assurance level of 2. That largely reflects the early stage of the work, and as that broadens out to cover system issues, we're expecting to see that increase. The only other thing I wanted to say on the report, Mark, is in relation to the transfer of functions for the mental health collaborative over the next few months. Sarah referred in her report to new guidance from the Department of Health in March on the delegation of functions, and we're now looking at something. There's a technical change for how we're doing this. We're now looking at a transfer of functions to us as the lead provider. The detail of what that means in terms of finance, quality and contractual commitments is still being worked through. This doesn't affect in any way either the timescales we're working to, or the level of commitment of partners, or our aim and objective here to maximise the benefits of formal collaboration. But we're not looking at the quite the same previous arrangement of delegation. We're referring to it as a transfer of functions. That's all I want to say.
Thank you, Jamie. And there's nobody showing, but could I ask, could somebody remind me when we as an organisation, and indeed the ICB, take the final decision on the transfer of functions, as Jamie's now calling it? When do we do that? Can somebody tell me, please?
October.
Well, it'll probably be the September board.
Oh, for October transfer, September board.
Okay, September board, and that's when, yeah, that's the final sign-off. Okay, thank you very much. And finally on our committee's end is the Mental Health Legislation Committee. Tessa.
Thank you, Mark. Again, for our new board members, the Legislation Committee is a slightly different committee to the other committees of the board, in that it's a committee where we invite all of our associate hospital managers who undertake the hearings for people who have detention orders on behalf of the non-executive directors, and I'm sure Jill will give a much more comprehensive and fluent explanation of that when you have your induction. But there's nothing unusual to report from the committee, Mark. Everything was reported as progressing very well and was given a assurance level. I think it was 5 or 6. Sorry, I've moved my page. 6. So all's going very well with that committee.
Thank you, Tessa. Any questions? I did have one. I found the paper fascinating, all the statistics, which laid out exactly our activity under the Mental Health Act. But the one thing I couldn't deduce was if we're doing okay, and that's not very technical, is it? But I can read all the numbers, but I couldn't tell whether that's saying we're doing okay, everything's normal or not. So probably Jill is the lead for that, and any of the clinicians after that. Are those stats telling me everything's okay, please?
It's a very good question, Mark, and one that we asked in the committee ourselves to say it all looks good. Are we doing okay? And Jill will give you the answer.
I think when we look at this, we use in many ways the 3 lines of defence of thinking about the assurance that we receive. So obviously the first line of defence, looking at operational services, we look at incidents, complaints, any claims or challenges to our use of the Mental Health Act. And in those areas, the evidence suggests that we are doing okay, to use that colloquial phrase. Then in terms of the second line of defence, looking at oversight of management activity, what do we see from audits and that type of thing? And perhaps the most useful from a board perspective in looking at levels of assurance, the third line of defence is what independent and objective evidence do we have? And so we do have the CQC conduct Mental Health Act visits to our wards where they look at the records held in respect to detained patients, speak to detained patients, speak to relatives, to actually assess from an independent perspective as to whether our compliance with the Mental Health Act is as we would expect. And whilst from those visits we get reports that we complete action plans, actually in terms of our management of the Mental Health Act, they very rarely raise issues about our compliance with the legislation. We also have internal audit are involved in looking at specific issues. Last year we did have an audit about compliance with a specific element, consent to treatment. And whilst that raised some issues, they'll be coming in again this year to demonstrate whether we have successfully embedded the changes. And we also then have other elements of objective assurance, so external accreditations. Some members of the board will be familiar with the AIMS accreditation that we've previously had on mental health in patient wards, which is an accreditation operated by the Royal College of Psychiatry. And we effectively, it's a externally assessed standard group of standards to look at the care that's provided and adherence to the Mental Health Act. So in terms of looking at those different elements, we try to bring those together to actually demonstrate as to whether we are complying effectively with the Mental Health Act. I think the one area that we've reflected on, and we have tried to do some work, is to bring some more qualitative data to that, to look at people's experience. And we have tried to do a piece of work talking to patients after when they're a little further down in their recovery, as to your experience of, for example, being detained under the Mental Health Act. To be frank, we didn't find that as helpful always, because some of the focus wasn't, from the patient's perspective, wasn't about adherence to the Mental Health Act. So we're now trying to actually do a similar piece of work with nearest relatives who are a safeguard under the Mental Health Act, somebody who is close to the patient, who has a role when a patient is detained under the Act, to actually explore with them, did you feel that your relative was treated with dignity and respect? Did you feel that the staff were compassionate? To actually look at it from that perspective as well, and that will be obviously brought back to the legislation committee. So that's in terms of looking at the assurance. I'm sure Natalie can put very much more a clinical perspective on that.
Thanks, Jill. So Mark, if I could just add, I think for me, the current kind of quality assurance that I would particularly focus on is the on-site advocacy feedback, which gives us a significant amount of assurance. They're an independent advocacy company around people's experiences. People report good access to on-site, they're well used, and it feels like a very effective route of giving immediate feedback and resolving concerns, which I think does provide some assurance around how effective and the quality of that. I also just wanted to raise something that we'll be hearing more and more about over the next 6 to 12 months, something called, it's the acronym's PCREF, which is the Patient Carer Race Equality Framework, which is specifically linked in relation to looking at mental health act detentions, which are disproportionately used for certain BME groups. So we know that particularly Black men are disproportionately represented in those statistics. So we're just starting on our journey. There's been some early adopter sites that have implemented the framework. So we'll be bringing more updates back to board about that lens of how are we doing with this? What is it looking like? And are we doing okay? And what other actions do we need to take? So that's work you'll be seeing more of.
Thanks, Natalie. Tessa, did you wish to come in?
Yeah, I just wanted to add that we really welcome this piece of work on the PCREF, or whatever we're going to actually call it, so we can remember what it stands for. But we have been talking for probably 12-18 months at the legislation committee about the need for more information about the EDI for Black minority ethnic groups. They're very small numbers in our area, but we just need to be sure that actually access isn't an issue for patients with mental health issues to our services, and indeed then that the Mental Health Act powers are applied appropriately. So we really welcome this piece of work and think it will add a richness to the information coming to our committee.
Thank you, Tessa, and thank you, Jill. Thank you, Natalie. I know that detaining somebody under the Mental Health Act is a serious business, and so having read the report and heard your explanations and indeed the look forward, I'm much assured. So thank you very much indeed. Okay, that's the end of our committee reports. Can I just thank the committee chairs and the executives that lead these committees? They're all working in a really difficult context over the last 12 months, and probably beyond that actually, and to keep seeking those improvements and focusing on the patient safety, patient care is evident from the reports that come forward. So thank you very much for that. I suggest we now take shall we call it a 10-minute break and come back at 10 to 11, so you can have what looks like 13 minutes for a cup of tea. So 10 to 11, please. Thank you very much.